Hello, hello, hello. Thank you all for joining us for today's webinar, Crossroads, Divergent Views to Meet to Unpack New HIMSS Virtual Care Research. My name is George McLaughlin. I'm the Director of Solutions Marketing here at Redox. For those of you who don't know, Redox is a healthcare integration and data management platform that exists to accelerate the development and deployment of digital health products and improve the lives of patients and providers. We solve technical challenges faced by product teams looking to integrate their solutions with healthcare organizations, electronic health record systems, and exchange data with a wide range of organizations. With customers on both the health system and digital health product sides of the market, we have a very interesting vantage point on the real world progress of healthcare innovation. It is through this lens that we work to gather interesting insights and share findings with the broader market, which is what brings us here today. For the past 2 years at Redox, we've seen a dramatic uptick in the demand for remote patient monitoring and care coordination solutions. With so much activity in this particular section of digital health, we wanted to learn more about what the key deterrents and accelerants to successful RPM and care coordination product adoption are. Our hope was to share lessons and best practices that organizations could learn from as they look to build and sell or select and implement these solutions in their respective organizations. To help us get to the bottom of things, we worked with HIMSS research arm to help us survey strategic contacts on both the health system and technology vendor side of the market. And we compiled a really interesting report. That report is going to be available in about a week or so in its full form. And all the folks who have registered for this event will get the first copy. But today we're going to unpack a few of the strategic findings. We have a really awesome panel to help us look into them a little bit further and unpack them. So first, we have Lauren Demosthenes, who currently serves as the Senior Medical Director of Babyscripts. Lauren is also Associate Professor at the University of South Carolina and spent many years as a practicing OBGYN physician. Lauren, can you briefly introduce yourself and give a quick summary of Babyscripts?
Sure. I'm Lauren Demosthenes. I'm an OBGYN in practice for many, many years, and then was charged at my health system to be the Director of High Value Care and Innovation, which I think technology offers both of those to patients. I came to a point in my career where I was given an opportunity to leave clinical practice, and I now work with Babyscripts as the Senior Medical Director. Babyscripts is a digital maternity health care solution that offers patients the opportunity to have less in-person visits, be more involved with their own healthcare by using home blood pressure and weight monitoring, with other things in the horizon for home monitoring. And this also answers the question of allowing patients to have more high value and efficient care, patient choice, and use digital tools. And then I also work in the addiction medicine space, teaching medical students. That's my background.
Thank you so much, Lauren. Yeah, so excited to have your perspective on this panel. I know at Redox, all of our customers are selling to health systems. Having that clinical champion on the health system side is integral. And as we'll find out later in the research findings, just having more clinical expertise is really paramount to the success of digital health products. So a really great example of doing that right over at Babyscripts. So next, let's hand things over to Susanna Rustad, who is the Chief Procurement Officer and Executive Director at UCI Health, for a little introduction of her journey to her role today and focus.
Hi, good day. My name is Susanna Rustad. As the Chief Procurement Officer, leading end-to-end supply chain, as well as the Executive Director of Virtual Care at UCI Health. This is where we've been able to take those components and assemble them into advanced care at home outside our traditional four walls. Our vision really includes transforming healthcare by building out a spectrum of care that's now possible and desired in the home. UCI Health is a bustling clinical enterprise of the University of California, Irvine in Orange County, which is home to about 4 million residents. We have the busiest trauma center in Southern California. We're ABA certified burn center, level 1 trauma. We are also serving a million plus outpatient visits, 50,000 visits to the ED annually, many surgeries, 20,000 a year. And we've embarked upon virtual remote care to address capacity and access issues. So we're expanding this care supply, and we're hoping to meet expanded patient demand, which requires an array of integrated digital care supply avenues. And really thrilled to be here with you today and to share what that journey looks like and how we incorporate suppliers and partners.
Thank you so much. We're so lucky to have you and your perspective here to share that with all of us. So then last, but certainly not least, let's introduce Erin Farber-Chen, who's the RPM Program Leader and Clinical Advisor at Boston Children's Hospital. Erin, can you give a brief little intro to everyone?
Great, thank you. Good afternoon, everyone. My name is Aaron Farber-Chen, and I'm a senior manager and clinical advisor overseeing remote patient monitoring services within the Innovation Digital Health Accelerator at Boston Children's Hospital. In terms of my background, I come from the clinical side where I served as a registered nurse in the clinical bedside space as our hospital was embarking on our journey from paper records to electronic records and working with electronic health record systems. Through that work, I began to get deeper into informatics and the technology realm, where I ultimately landed within our innovation center at Boston Children's Hospital, where we serve or do work in order to expand access, improve the bedside care experience, and enhance care both locally, nationally, and globally to expand pediatric care and broaden the expertise of Boston Children's Hospital around the globe.
Fantastic. So as you can see, we have an awesome panel with diverse backgrounds and experience to provide some insights from what it means to actually be building, deploying, selecting, integrating RPM and care coordination and other digital health solutions. So you're in good hands as we unpack some of these findings. So just a brief overview of the research that we embarked on. We worked very specific with which types of roles and what types of organizations that we surveyed. So on the health system side, the results here are from 100 qualified respondents. And if you want more details on the full scope of the survey and the participants and everything, that will all be available in the final report that will be made available by Redox. And again, everyone registered here will get a copy as soon as the final stylized version is available. But here's just a quick overview of the different functions and roles of these respondents. On the digital health vendor side, a little bit fewer qualified respondents, but again, very high quality titles and organizations that we worked with here, so that you can trust that these findings are representative, and as we unpack them further today. Again, for more information on the full research and report, that will come later, and you can always reach out to us for the findings. So today we're just going to call out a few key areas. We have an hour here today. We're 10 minutes in, so we're going to spend the next 40 minutes or so going through a few of the key findings and helping our panel unpack them. And then we will save time at the end for questions and answers. So I would encourage the audience to ask questions as we go along. There is an ask a question button at the bottom of your screen. That's the best way to ask a question, because then other participants can upvote. And with the time that we have at the end, we'll make sure to get to what is the democratic most important question. All right. So to get us started, we are going to look at an interesting finding of what is the biggest obstacle that health systems ranked when considering a third party or RPM or care coordination solution. So when they were talking about introducing this into their organization, 47% cited incompatibility with EHR and enterprise systems as the biggest deal breaker. So when selecting a solution and choosing to incorporate it. So that was far and away the number one result. There's also lower on the list, but lack of validated ROI and data limitations for clinical use were deal breakers in selecting one of these solutions from our surveyed respondents. So to get us started, I'd love to kick things over to Susanna to get some insight on what she sees in her day-to-day, on the procurement side. When you are looking to select a third-party solution and introduce it, deploy it across UCI Health, what do you see as the biggest obstacle? Do you see this incompatibility with EHR systems as an important thing that you work to get in front of, or is there something else that you'd like to share with the group as what you care about most?
Yeah, absolutely, George. This data resonates. So as we are going through the process of identifying criteria and selection process, incompatibility with the EHR was definitely deal breaker number one. So many in our health system definitely aspire to have our EHR to be is the end-all be-all system of record, the one source of truth. Everything must connect. The data must flow into this one-stop shop for convenience for our practitioners and the clinicians. Sanity, frankly speaking. In fact, the genesis of our programs that has been at the forefront as a guiding principle. So pragmatically speaking, it's also too resource intensive for us and our ITIS teams to be building interfaces and that connectivity for individual use cases. So what we're seeking are platform solutions where we can have discrete values at various frequencies, and we can provide that data that's needed to establish trends for clinical use. And it can be in the form of HL7, it could be in the form of middleware. In our experience, we've had both. So limitations of just pushing out a PDF record, which many solutions have that as an option. But to us, as a healthcare provider organization, that's static. So unless we manually pluck that, it's really not meaningful use. So it might be doable for a pilot, certainly not scalable and not acceptable for the long run. The second one you mentioned, George, is deal breaker number 2, validating the ROI. Yes, we have a discipline, we have a process for conducting that due diligence. So we have so many committees, as you can imagine, at an academic medical center that would review the business plan, that strategy, capital planning committee, there's IT governance, PM steering committees to really allocate resources for that build. If there's medical device involved, we have value analysis committee. So there's a lot of activity and development right now, especially with RPM requests, that we're even in the midst of forming another committee. So the framework for new innovation forum is we're trying to create a funnel for all that intake and decision making through a macro enterprise-wide lens. So all in all, we're balancing that clinical appropriateness, the economic viability, and value creation. So this definitely resounds.
Great answer. And, from our standpoint at Redox, we've been at this for 8 years, and the whole purpose for Redox is that idea of point-to-point solutions between this whole world of digital health solutions and healthcare organizations just never made sense. Like at a macro scale, it just really doesn't. So citing those platforms and those middleware as you're looking to build that and hearing directly from you that is important is really interesting. One quick question I had for you is that in this space, right, incompatibility with EHR and enterprise systems, the answer from an EHR system is just buy our stuff. Don't buy anybody else's stuff. Is there anything that you have to share around why you still would choose to use a third-party RPM or care coordination solution instead of, there's a lot of great functionality from whatever EHR organization is using, but why you can't just rely on that single vendor? And if that's not something you want to talk about, that's totally fine. I'm just curious.
Sure. So this is for me, George?
Yeah.
Yeah, I think, why do we have medical specialists? So as far as our physicians go, we have certainly multi-specialists for a reason. And it's because, having a one and done is a great aspiration. But there are many, many, many clinical issues, operational issues that we're trying to address that one entity certainly has not and is, at maybe some point in a long distant future could possibly do it all very well. So I guess it's where why don't we buy all of our supplies and medical implants from one company? Because that innovation, it happens on so many dimensions. And I would sort of correlate this to our procurement platform where we have procure to pay. We also subscribe to a hub. It's called Global Healthcare Exchange. We're not building out individual e-commerce connections with each and every of our 5,000 suppliers. That would be so intensive, and the outcome would probably be not as good as using the spoken hub approach. Great,
super interesting perspective. So next, I'd like to go to Lauren. So Lauren, I know you have some really interesting thoughts here because in your role traditionally as a clinical champion, you cited that EHR incompatibility was not top of your mind. Like you were thinking about a solution that was going to improve either your role as a practicing physician or for your patient's experience. So could you just shed your perspective on for incompatibility of solution, just how you view this?
Sure. So my journey started as a frontline clinician who really made a lot of assumptions that anything that I wanted to have for my practice would work and that the IT people would take care of it. And my assumption is that I want to take care of my patients in front of me and I want it to be efficient for me as a provider and that the rest of it was a given. So the interoperability was not something top of my mind as a frontline clinician because I thought somebody else would take care of that. As I became more involved with a third party, as Susanna mentioned, I think third parties sometimes have a better solution than what the EHR can provide. It became apparent to me that that a lot of frontline clinicians just don't know about all the things that are behind the scenes. So if you were selling to me, I want something that's going to work when I go see my patient at the bedside in the office. So thinking through it, I do want it to be integrated, but I didn't even know about that as a frontline clinician. I just made an assumption that would work. I also want something that my staff thinks is easy to implement. I want it to work into my workflow. We do want it to have an ROI because we need to know that it's improving our business model. I hate that, but that's sort of the business of medicine. And I've been told that before, is you just, it's not all about the patient. It has to make business sense. And as a physician, I never wanted to think that way. So I do think in terms of third parties and EHRs and making these decisions, you do need to get the frontline clinicians and nurses involved because we're the ones using it on the front line. And we want to know, why did you buy this solution? Is it going to be hard for me to implement? Is it good for my patients? Is it good for my staff? Does it fit into my workflow?
Incredible perspective. Yeah, I think, we're in the healthcare technology space and we can really get stuck in the weeds of the systems and everything, but it's always important to bring the patients and the providers to the forefront and really listen and hear from them and what's most important. So I think that's really important to call out. So Erin, you have a really interesting role here. Like one side, you're a clinical advisor. You're also thinking about, RPM programs broadly for Boston Children's. Is there anything of this, what was called out here that stands out to you or that you'd like to shed some insight on?
Yeah, definitely. Thank you. So I would certainly, echo and add on to Susanna's and Lauren's comments. As I would say, in my experience, both as, a clinician at the bedside and then flipping over to the technology side, with optimizing EHRs and launching other digital tools, clinicians are most often concerned with getting through their day, and caring for their patients over sort of the technology, nitty-gritty details. However, the use of technology, which is essentially ubiquitous in healthcare, mostly due to the use of EHRs, does have an effect on the completion of their work. And the ability to do so efficiently given their competing demands. And having all needed patient information in one hub, such as an EHR, is definitely ideal since that is where they spend most of their time. And so this is where clinicians are interested in technology, which fits into their workflows and requires minimal time and effort and without extra cognitive burden, all of which can take away from their primary job of taking care of patients. So if clinicians have to navigate multiple systems or have to manage data between systems themselves, that ultimately takes away from their time and attention to care for their patients. Boston Children's, just for example, has worked to procure novel and innovative solutions based on the needs of our clinicians and staff. But given the limited interoperability between those systems, we've had to spend considerable time, resources, and effort in developing custom layers to manually stitch solutions together, which is certainly not ideal and has long-term implications, similar to what Susanna had mentioned. And so the bottom line being that although it's not top of mind for them, the clinicians, interoperability does have a notable impact on a clinician's ability to complete their day-to-day work and to do so effectively and to be able to support an innovative environment.
Really great stuff all around. It's on one side, it sort of breaks my heart because at Redox, I've been here for over 6 years and the goal is that this wouldn't be the biggest issue, but it's really important for this type of research and for you on the panel to help everyone call out, this is the reality. This is still an issue and this is, limiting the adoption. And even we do find a tool that, a physician wants to introduce, there's all these hurdles to still get over. So really interesting perspective to share. This is something I hope if we did this same survey in 2 years, 3 years, it'll be drastically different, but really important for everyone on the call to realize the reality of the status quo. And if you are building or implementing one of these solutions, you have to have a strategy to get in front of this or it will be a deal breaker. So we're going to move on to our second finding. And the finding for number 2 is it's on the flip side of things, where if compatibility with an EHR is a deterrent, let's look at something that helps demonstrate success. So in our research, overwhelmingly, health systems rank the demonstrable ROI as the primary indicator of RPM, care coordination, adoption, integration success. Susanna touched on this a little bit, but we'll go into it a little bit more in this. Interestingly, and part of the point of this conversation to unpack these findings is that in our survey, tech vendors actually ranked this quite low in comparison. Health systems said ROI, number one. That means the product was successful, whereas tech vendors had different answers. So what I want to do is just kind of unpack that discrepancy and get some more perspective on the value of ROI, and then also the difficulties in measuring ROI, and then maybe what else like a solution would value, or even a physician or a patient might value. So let's start with Aaron on this side of things. So Aaron, we had some conversations before this live session about there's some difficulties on effectively measuring ROI. There's like a goal of it, obviously, but in reality, it can be a little bit hard to pin down occasionally. Can you share your perspective on, well, one, the value of ROI, like demonstrable ROI, but also the real life kind of limitations currently in some settings?
Yeah, absolutely. So remote patient monitoring ROI for Boston Children's, as you sort of alluded to, has been challenging to determine a bit. Part of this is because caring for pediatric patients is quite different from caring for adult patients. Pediatric health needs and disease states don't always require the same kind of management as those conditions found in healthcare. For instance, in the adult population, common conditions such as hypertension and COPD, just to name a couple, may warrant more regular monitoring at home for improved management and clinical outcomes. But with more consistent and frequent monitoring, these cases may meet the criteria for billing and reimbursement per the RPM CPT code guidelines. Since there isn't as much frequent monitoring with aspects of pediatric care as compared with adult care, it's been necessary to look at other opportunity areas to see that ROI. In addition to trying to determine the RPM clinical outcomes, we are also looking at other metrics that may support ROI. These metrics can include staff time savings to focus on more high-touch care needs, reduced care and associated costs, and improved access and hospital capacity by more closely monitoring appropriate patients at home to limit their need for hospital care. And so in short, it's not easy for an organization like Boston Children's to fit nicely into the flows supporting ROI that are developed by vendors. And it would be helpful to have flexibility in measuring ROI beyond RPM reimbursement potential. And we continue to interface with vendors to discuss and review pediatric specific needs in the RPM space.
So just out of curiosity, this is one thing that I'm always curious about in this space is how do organizations share like best practices and findings? Like, do you have any thoughts on like if Boston Children's, you're constantly evolving how you measure ROI, is there a way that you share your learnings with the broader like medical community or outside of Boston Children's to help, set a precedent or maybe help others understand what is a way to measure ROI other than, this reimbursement went up X percent?
Yeah, definitely. So we certainly work with a number of vendors, and we interface with them not only to learn about what they're doing, but then also that we can share about how we're doing our work to try to sort of come to a meeting of the minds or sort of middle ground in the work that we do. In addition, there are a number of I would call them SIGs or special interest groups that pull together a lot of pediatric organizations to try and rally or lobby and put together content and information and materials to support sort of our needs and interests to be able to disseminate that to interested parties as well. So there are a couple of different ways that we try to do that. It's not always easy or simple or straightforward, but we do the best that we can with what we have in order to sort of get the word out.
Well, thank you so much for sharing that. Let's kick it over to Lauren. So Lauren, so I know you have interesting thoughts. Again, you talked about, unfortunately, you have to always bring up the business side of things, but you also have obviously a clinical bias. So what are your thoughts on, measuring the success of the adoption of a product and what really matters?
So again, the company I'm involved with now, Babyscripts, is a maternity care company. And much like Aaron, it's a very finite period of time. So it's less than a year that we're involved with the patient. So if you were to rely on just dollars and cents as ROI, it would be difficult. So a lot of times we can't meet the CPT code requirements. Some states actually are still fee for service. And so in-person fee for service. And so there's really a disincentive to offer patients remote monitoring because we really would have a higher reimbursement if we asked that patient to come in. And that's so unfortunate, because when we look at other ROIs, it's for the patient. So let's say we have a patient who's trying to live in a family with one car, and she really doesn't need to come in for 12 to 14 in-person visits. And we know that because I'm working with ACOG on that very thing, that we really need to reinvent prenatal care. We don't need to have people come in person. We still need touch points. So here we're asking a patient to leave her home, possibly take off half a day of work, possibly get a babysitter, drive in, pay a parking expense, possibly sit in the office for as long as an hour for a probable 10 to 15 minute visit. And, from an ROI, from what this is costing the patient and her employer and her home, it just isn't right. Also an ROI on, do we want to be the kind of physicians who offer our patients choice? So I want to be able to tell my patient, you know what, we have a lot of ways to provide you maternity care. You can have midwives, you can have digital care, you can have group prenatal care. To me, that's a tangible ROI, that we're offering more than the traditional service of you must come in person, you must see a doctor, you must deliver at a hospital. Those are so intangible, though. And right now in our current healthcare system, those are not necessarily valued in terms of money, but I think they're very valuable to where we're trying to go with healthcare. We're trying to be patient-centered. We're trying to save, patients are bleeding out financially from healthcare costs. So we're trying to provide them options that may save them money on another aspect. Happy to have questions about that as well.
Amen. I think that was awesome. Yeah, I think that's something we see in our day-to-day, right? There's very often this issue, in healthcare, and it's just constantly evolving, but that these solutions that have value and these people that really care about changing this, but then if you can't tie it to ROI, you can't tie it to reimbursement. I mean, it's an ongoing thing, but I think it's really important to call that out. And just as an industry, we're going to need to keep pushing to evolve that. And maybe it's a mix of these, special interest groups that you talked about, Erin, and just sharing this collectively, and then just kind of continuing to push and advocate for an evolution of how that works. Because, yeah, that's what we see all the time, is that there's so many of our digital health partners that are offering these amazing alternatives to this traditional. But to your point, at the end of the day, it's like, nope, get in the office, be here the 13th time. And then, yeah, you did a great job of highlighting those various social determinant of health impacts and how all those things. So thank you very much for that. So to close us out on this topic, because we do have other ones to go into. So Susanna, as a procurement officer, you have very sophisticated thoughts on measuring ROI and what you've seen work and how you evolve. So can you share your perspective on the importance or some best practices that you've all been able to implement?
Sure, I could try to share some additional tangible advice on measuring that ROI and how we're looking at it holistically. So our stance is really about building that foundation, and we're investigating the multiple dimensions that Erin and Lauren have described in detail. So those elements are not only the financial model, right? It's the clinical model, the operating model. Those all have different costs and expense. The engagement model, the technical plan. So the economic model, we know that the ROI won't necessarily come right away, that there's an upfront investment and there's incremental costs. So our pro forma, what are our assumptions and our path to that future utility and ability to scale? So that's important too. So that's what really goes into the making of that ROI case. I'll mention three important aspects of costs and expense and potentially how that revenue offset goes into the making of that ROI. Certainly, we believe that the system integration, which we've talked a lot about, is key to bringing that data back into our EHR to create a holistic patient record, to really bring down the burden and the burnout of our clinicians. Secondly, the operational integration, often overlooked, is how do you onboard those patients? Whether it's the post-acute route, the chronic route, embedding that onboarding of patients into our EHR, baking it into the clinical tools, is also the ease of use, which is also tied to labor costs, et cetera. Easy to contract, and we can talk about this as we get further into the financials, but We know that there's difference between capital expense versus operational expense and how that is treated financially. So having different ways of structuring this and flexibility for your client, your customer, your health systems, whether that's per member per month, what are the upfront implementation fees? Does it cross any sort of thresholds? That commitment. I mean, if you're building something that you believe in, you don't necessarily have to transfer that risk all up front to your customers, right? So true ROI and the other mechanisms in which we calculate this is reducing length of stay, early discharges. So we have patients in waiting, patients on the sidelines that can come and backfill. We look at patient satisfactions, patient benefits, and better outcomes. And better outcomes means that we're reducing recidivism, we're reducing the ED visits for those high utilizers, reducing those bounce backs and adverse events. Patient adoption and whether or not they're going to be wearing their prescribed time for the program, whether or not they're adhering to those daily symptom checkers and questionnaires, and helping to bridge that adoption divide, digital divide. How does this help with health equity? What are other diverse needs? Are it all of our multiple languages that our community, a diverse community has, are those being represented so that it can be a program that can scale? So I'm trying to find these concrete ways to demonstrate and measure improvement in outcomes and patient satisfaction, taking cost out of healthcare, not just the hospital. I think that total economic impact, the more that the technology solution provider can bring upfront to the table to demonstrate that it's well thought out, really helps us on the health system side to be able to push the envelope when it comes to implementing solutions.
Really, really great stuff. And for everyone, this will be recorded, will be made after. I was just taking some notes on, I think, you should listen back to Susanna and all the different ways that you could present measurable ROI to make a compelling case. She gave some really good examples that she thinks about in day-to-day and works with products as well. And I think that's all, really fascinating conversation around this. We're going to keep moving just for time to the next one, although the next one is related in a way. So one of the other findings in our report was pricing. And this is something I'm always interested in too, is what do people actually charge for these solutions? What do health systems pay? It's a little bit unknown. There's an effort for price transparency for, care is happening in healthcare. I think 2 big fines actually came out for the first time, which was interesting in kind of the last couple of weeks of not prescribing to CMS price transparency. That's different from this, but it's interesting that there's moving towards transparency in the market. So in our survey, we found these were some examples of what a solution costs. And there was a big discrepancy actually on health systems vetting the cost, like what they had budgeted in this 100K plus per solution. And then vendors themselves had answered they were only charging 51 to 100K. So again, this is a representative survey. It's not all exhaustive or inclusive, but I thought it was interesting to actually have dollars associated with things because we rarely see it actually. So as we unpack this finding from the results, Susanna, because you were just talking about measuring ROI, and I had asked you to kind of prepare thoughts on palatable pricing models, I'd actually like to start with you again and kind of share, what's your reaction to these costs, if there's anything, and then otherwise, from the procurement side, do you have any thoughts on best practices if a solution is selling to a health system? What are pricing models that are palatable? You talked a little bit about like operational and capital expenditure before, but yeah, just any insights to share here on pricing models that make sense from your side of the world?
Yeah, absolutely. So part of my responsibility and my role is the strategic sourcing and contracting. So any spend, we have very strict requirements from the University of California. So we are beholden to state policies, federal, as well as local. So we have very, very just distinct things that we're looking at and thresholds that really determine how complex a process will be. So something to think about is maybe understanding your client, your customers, what their obligations are, and to understand how to navigate that. And certainly capital is one of those things that there's competing priorities always. So there could be technical debt, there could be just infrastructure and there could be growth in a lot of desirability to expand our footprint, our services, our geography. So those are the competing forces. And when you're looking at technologies, depending on where it's applicable, is it service line level or is it more global, enterprise-wide? Is it something that has different touch points? It could certainly determine the price tag. But I guess the primary consideration is to navigate whether capital expense involves a lot of layers, a lot of committees, a lot of approvals, what those thresholds are. And then on the operational expense, could you go one way or the other, or is there a hybrid that you're looking at? Either way, if it gets to be of a certain caliber, we're talking about having to look at things that are offsets. So what is your per encounter cost reduction, or is it capital avoidance? Is there going to be some sort of reduction in spend because you're shifting a site of care, or you're going to be improving care? A lot of organizations have at-risk, value-based, or population health. Maybe they're on capitated models. That's important to figure out too, is how they're structured in that sense. What is the revenue impact of what you're suggesting? And is there additional revenues that could be put into that model? So I think at the onset, you have to understand how things work on the health system side, and who are all the relevant folks that could be part of that conversation to really help to flesh that out. And then figuring out how to navigate it is key. Otherwise, any one of those doors could close, and that could be the end of the conversation.
Super interesting insight. I mean, I know, so like on our side of the house, right, we have a big part of our audience are builders, folks who are building solutions, and you're their target, trying to convince you or sell to you and whatnot. So providing your perspective on what you think about, what you're looking for, is really invaluable to that part of our audience. So I really appreciate that. Let's keep it on the health system deciding side of the house for now. So Aaron, what are your thoughts on this, or any advice that you have to share about pricing models that you've seen are particularly palatable or interesting from your neck of the woods?
Yeah, absolutely. So in reviewing this information, I think these figures are somewhat on the lower end, as it's important to consider other associated costs that can or are co-occurring and go beyond the basic software or platform costs. For example, we at Boston Children's leverage a shipping, retrieval, and cleaning service for our RPM devices to ensure that we have sufficient quantities for our clinical departments when needed for their patients. And since this is not something that we do internally, nor would we necessarily want to, we utilize the logistics services that are provided by our vendor, which adds to our costs. For other vendors, we found there are other services that in some cases that come as bolt-on additions, which can encompass other capabilities such as staffing support to manage RPM data and or platform integration with healthcare systems, depending on the need. These costs can add up quickly. And so I think it would be helpful to have as much clarity as possible about those services, the associated costs, and if they can be included or excluded if and when needed to ensure that healthcare organizations have the services they require to launch and scale programs efficiently, but also in a cost-effective way.
Great insights. Lauren, let's, and I, just watching time, and I do want to get to the questions, so I'm moving a little quicker here. But Lauren, from your side of the, you're on the product side. Is there anything to share about how you all have priced Babyscripts or evolved that over time that you'd like to share?
Yeah, so I think, of course, we understand that there has to be an ROI for the health system to purchase it. I also have seen a little bit of a disconnect of what can happen when a health system sees the ROI, purchases the solution, knowing that in the long term, this is a good solution. We need to move forward. We need to offer this to our patients. But the frontline clinician is sort of handed the solution without as much leadership support as they need. So they're just sort of introduced that here's the solution, but then there's really no accountability. And so the health system has bought the solution, invested in the solution, but really not communicated to the frontline provider that we want this to work and we want to partner with you to make it work, and what can we do so that you as the frontline providers can now make it work? Because if the health system buys the solution but then doesn't hold the frontline accountable or get their buy-in, it may not work very successfully. Does that make sense to you?
That makes total sense. I mean, we see that all the time. We talk to our clients. It's like, it's one thing to make the sale. It's one thing to get the renewal. Like you have to actually see the adoption, the utilization, and then have the successful deployment. So you have to understand everyone that's going to be involved and make sure that it's successful. And I think that's a really interesting perspective of, hey, start using this. We're really excited about it. It's great. But if they're not in lockstep, you can see how that could, go off kilter really quickly. All right, so I do want to keep us moving. I think I have a lot of follow-ups I could ask, but I'm going to hold off on that. So for our final planned topic, before we get into questions from the audience, I want to review some of the accelerators of successful product deployment. So first and foremost, across both audiences, a clearer understanding of clinical workflows was the top accelerant identified by both groups for successful product adoption. So keep that in mind. While focusing on that, that might be the best use of your time. We also want to call out the areas where there was a big disconnect between the responses of health systems and then the product teams themselves. So on one side, more experience across EHRs was cited as something that would vastly accelerate a product's deployment timeline from the health system side, but only 14% of tech vendors called that out explicitly. And then having a detailed deployment timeline and understanding of exactly what needs to happen. Health systems called out as the number 2 reason for a product being successful, integrated, deployed in an efficient fashion, while tech vendors had that low on the list at number 6. So for this last group panel, before we get into questions, this is going to be dealer's choice. So I'm going to leave it up to the panelists to determine what of this area do they want to talk on? Do they want to call out how can we better support better understanding of clinical workflows for digital health product teams to lead to success in product deployment and use? Or why is EHR experience difficult to come by? What is this issue in our industry that is leading to issues in product deployment and adoption? Or finally, what is the value of more detailed timelines? What goes wrong if they don't exist? So I'll kind of let the panelists pick which of these topics is of most interest to shine a light on. And let's start with Lauren.
I'm glad you're starting with me. So, I feel like you have to really have a successful pilot, and then the successful pilot needs to be championed by a frontline clinician, and then the frontline clinician needs to get some support from leadership, because the frontline clinician who is a champion is usually extremely excited, wants it to work, gets it work in a small pilot, and then things, it needs to continue. And the only way it can continue is with leadership. I say that because I've been the frontline champion, and we had a successful pilot. And I've also seen that now with such turnover in medicine, you can have a team that's really excited and it goes really well. And a year later, there's a new team. Especially when you're working in an academic medical center where you have residents coming in and out who are often very involved with delivering the healthcare. They're just trying to stay alive in their 80-hour work week. And so, you have to kind of keep them in the thought process as well. So I'm pretty, feel very strongly that you need to go from pilot with a champion, with clinical leadership support of the champion, or else the champion can also burn out. And they don't burn out as quickly as the frontline.
Fantastic perspective. Let's go to Susanna next. So of dealer's choice, of those 3 things, anything that stood out to you?
I think I'll make a couple of points. Simply stated, from a health system perspective, we need help. Right. Everyone is bombarded with information. Our clinicians, their primary function is patient care, not implementation of new programs. Staff wellness is something they're thinking about. We have wicked labor shortages and operational priorities. So the internal demands are high. So how will these limitations of the healthcare system impact your success is a question that you should ask. Have you thought about the impact to the culture? So if you want to accelerate deployment, think turnkey. So you have a great solution, it's slick, right? It truly addresses the pertinent needs that resonate with the last mile of care delivery. But what are the plans for change management, operationalizing and optimizing those workflows, the implementation plan, those timelines, all the resources that go along with that? Being able to articulate this upfront is something we look for. Gantt charts, tell us what are the stakeholder groups that we need to think about, and we need to go identify somebody to be part of the project. So all that inclusion, rollout of communications. Do you have FAQs ready for us to copy and paste? I mean, health systems do not have resources on standby at the ready to work on these type of projects that crop up. So if your solution is complete and you've thought about all the angles and all the pitfalls are addressed and you have them at the ready, that's what's going to help you accelerate deployment.
Amen again. Amen again. That's that. I think there's a lot we could all learn from that. All right, Aaron, on this topic.
Yeah, definitely. Probably echoing a lot again what Lauren and Susanna already touted to the audience here, but definitely wanting to do that sort of upfront work and making sure that there is as much information as known and understanding about your customer or about your partner. This is a really crucial point where there can be gaps and where there is a lack of clarity on the goal and how the clinicians function in their respective clinical areas, since not a lot of areas are the same. And I think that's really the main point. And so my biggest point of feedback would be to vendors that every organization is a little bit different and requires sufficient investigation and analysis to help to ensure that the proposed solution works well in the end. And with so much variation, organizations differ from adults to pediatric to cancer centers to academic medical centers to rural critical access hospitals. And each one needs to be carefully considered, since a one size does not fit all. And just because it works in one place, it may not work the same way in another. So the takeaway message for vendors is to take time to really get to know your healthcare partners and their features before moving ultimately into implementation.
Incredible stuff. There's so many, additional follow-ups and things I wanted to do, but I want to get to the audience question and answer. I really appreciate all of you for participating and helping us unpack, these findings, provide your really incredibly valuable perspective on it, and to just go deeper. As a reminder to the audience, there's more findings within this report and research and other interesting things to glean from it that we're excited to share with you and for you to reach out to us for. So I'm now going to get into the audience Q&A. And again, I'm just going to go down the list of order of votes. So you still have a chance to vote just to try to see what we can cover. Obviously, these are very important people on this panel, so we are going to stop on time. So these next 12 minutes, I'm just going to see what we can get done. Okay, so the first question comes from Farber-Chen, and this is financial ROI more important to health systems, or is the clinician pain or patient outcomes more what vendors should focus on? Anyone want to jump in?
I'll jump in here quickly. I would say, quite frankly, I think it's a little bit of both. I don't think that it's necessarily one versus the other. Especially as I mentioned earlier, we can't always necessarily get to the financial ROI because of a lot of different factors, whether it's related to things internally or related to regulatory issues or reimbursement related issues, legal issues. And so I think we have to try and find the best areas to be able to work and get to an ROI. And sometimes we have to be a little bit more creative in order to do so that goes beyond that financial ROI. So it could be related to efficiencies with time and staffing, and it could be related to patient satisfaction ultimately, and the costs that they assume, similar to what Lauren had mentioned earlier. So I think it has to be multidimensional. I don't think it's necessarily one or the other.
I also think it varies between who you are proposing your solution to, as Aaron mentioned. So one place may be very focused financially. Other people are more focused on patient satisfaction. So I think, again, you have to really tailor it to the person who's buying it.
I would just add all of the above, right? Financials, sure, they're important, but you have to get beneath the surface of that because there's so many implications. So sometimes when you're just scraping the top, You're not addressing things like provider burnout. Oh my goodness, what kind of financial implications does that have? So I think as folks recognize that it's very complex, and we have to really look at it certainly in a well-balanced way. There's so much more to the story than just a number.
Fantastic. And again, if you rewatch this webinar, there's a lot of really tactical advice on how to make a more sophisticated and nuanced ROI argument. So take those notes. All right, so our next question is from Abe. Do your organizations plan on implementing so it's RTM program, I'm guessing that's real-time monitoring program, in order to help patients with at-home medication adherence and add an additional stream of revenue? So this is for Aaron and Susanna. So real-time monitoring program with medication adherence. Have you already adopted a solution? Is it on the strategic roadmap? Any insight to share here?
Aaron, would you like to go first?
Sure. So in terms of RTM, I understand it as remote therapeutic monitoring because that's okay. So there are some CPT codes that now allow for reimbursement related to remote therapeutic monitoring. So we at Boston Children's, I can just speak for us. We haven't necessarily gone into that realm just yet. We're still working more on the remote physiological monitoring, but we are interested to see, specifically within the respiratory and the musculoskeletal domains and specialties, since that's where the RPM reimbursement comes into play, and then elsewhere to see how best we can support our patients with those types of tools. But I think that's more for down the road for us, while we still assess and better understand how we can serve patients with the RPM modality.
Awesome. And thank you for helping. I flub up healthcare acronyms too often, so I'm glad the audience wasn't sitting there. That's not it.
So at UCI Health specifically, not at this time yet, but we are evaluating our care at home options, and we put together an entire engagement project. So we're involving many of our key stakeholders. We're holding focus group sessions. We're really trying to identify all the work that is happening in various areas so that we can provide a cohesive 3-5-year strategy and roadmap that we all agree upon is embedded into the enterprise strategy. So it's something that we're looking into identifying, and not specifically just yet.
Thank you so much. And I guess, Lauren, is there real-time therapeutic management something in Babyscripts world? I don't want to be rude.
So I will say that Babyscripts has the ability to actually monitor certain things real time. So that's sort of the benefit, is that if we do have a blood pressure trigger that's in a dangerous zone, we do have real time capabilities to let the provider know there's a serious problem and that we need immediate intervention. So I think that's important.
Awesome. Thank you so much. All right, we are going to keep going down the list. So we have, so this is from Shelly. This is another ROI. See, everyone trying to figure it out. There's no easy answer here. So what makes ROI for an RPM solution demonstrable? What do tech vendors need to do to make their cited ROI numbers more credible? That's interesting. Any thoughts there on the, I guess, if you get this, we're going to save you this, how do you go into, do I believe you or not?
It's more credible if there is an actual reference. So sometimes that performance is built out in conjunction with customers that they have already implemented. It's also more credible if there's a actual model where you can tool in or pipe in your specific numbers and it spits out a magical solution number. That shows a level of sophistication in that realm that probably is not conveyed when it's on a PowerPoint or in Excel.
Great. All right, let's just keep flying through these. So this is an interesting one from Rachel. So the labor shortage and staff wellness resonates with me. Who within the institution is struggling the most with labor shortages? If our solution can help with that challenge, which department would be the best to approach to address that issue?
I'm on the healthcare side, so I know the nursing shortage is extreme. I know there are certain places in the country that have lost more than half of their physicians in the past year. So I think, again, it depends on where you're located, but it's really, really happening in terms of nursing for sure, and even physicians. But sometimes I think there's some reluctance to introduce something new that will ultimately save time. So think there's this thought process of, I'm hanging on right now. This solution will save time in the long run, but right now, do I have the capacity to learn something now that will benefit me in the future? And so I've seen this burnout playing out, that those left behind are just, they're unlikely to embrace the solution that requires upfront work. So, I mean, I think there's some places that see the long term, but there are some places that it's just a day-to-day survival.
And I would just add, in terms of an area that is really hurting and really in crisis, and I think this is not just within pediatrics, but in all of healthcare, is behavioral and mental health. And so it is hugely significant in terms of the lack of providers that are needed to meet the challenge and the crisis that's going on sort of across the entire healthcare continuum and spectrum. And so we're trying to be as innovative as possible at Boston Children's to see about, are there ways that we can use digital health tools and other modalities to better support our patients with behavioral and mental health needs, to better meet the demands and treat them as best as possible.
And I'll just add that certainly the ancillary and support roles are also very taxed when it comes to labor impact and availability of workforce. So this would be culinary nutrition, this could be environmental services, it could be supply chain. So in many of these other areas, we are looking, because we don't have license ratios and requirements. In many of these areas, I believe automation, robotic process, RPA could be great solutions to address. So I wouldn't discount the other areas as areas of opportunities either.
Really, really fantastic insights. Yeah, I mean, it's in the digital health space, people get so excited about their tools and why aren't you just adopting this solution, or it could save all these problems, and then just getting back to the reality of the people and what the day-to-day and where the priority, of what needs to be addressed or solved first is something everyone needs to continue to keep in mind. So I think we have time for one more question. So I'm actually going to pick the one because I want to hear from the vendor side. So I think this is an interesting one from Sarah. So this is for Lauren, but I think Susanna and Aaron can also answer this. So Lauren, how does Babyscripts try to drive accountability with their users? So pilots can leave health systems without a lot of skin in the game. How do you avoid that? So I think what she's getting at is this concept of a product saying, we're going to do this pilot, maybe we'll do it for free. And then if you do it for free, people aren't really involved and then it just kind of dies on the vine. Like, do you have any insights on that type of accountability or that increased collaboration across everyone that matters and actually making the adoption and use of a product successful?
Yeah, so Babyscripts is trying to be there at the elbow of the frontline providers to help them implement. So as we've mentioned before, pushing the button in the order set to do it is really not the answer. You can do that, but then somebody has to explain to the patient what is the benefit of this. So I think we need to be there as vendors with the customer really on an ongoing basis, because we know that they have challenges with implementing and then sustaining it. And we need to be there to share best practices, put them in touch where pilots have been very successful, and really learn from each other, from peers of, gosh, we had that problem. This is how we overcame it. Have you tried this instead? I also think it's interesting to know that you might be selling to a health system with multiple practices. It may be wildly successful at one practice, and then it may not be wildly successful at another practice within the same health system. So I think you have to have ongoing conversations about why it's successful here again, remind the front line that we're doing this for our patients for the long haul and why our leadership chose this solution, and keep reinforcing to the clinicians, this is good. This is a good thing. We know that it isn't always about paying the clinicians. It's just supporting them and giving them some positive feedback of, we really appreciate the work you're doing to bring this to our patients.
Well, thank you so much. So folks, we are at time. I'd like to thank our panel for being just incredible and sharing your insight and perspective. It's super valuable. I think it's just so important as an industry that we continue to share this as we work through these tough problems. Aaron and Susanna, do you have any final thoughts to share? I know we do have people got to get on with the rest of their day, but if there's any closing thoughts, just give everyone a second and then we can just get out of here.
Yeah, on the last question there, I can just add that there is a way to put some formality and structure around a pilot. If you want to insert some sort of structure and steps in the statement of work, this is always something where you can put specific goals in, and if you reach them or if you don't reach them, you have a plan in place on how to address that so that there's no sort of cliff. You have a very good plan to keep it going, or to at least have some closing of the loop. And so just in closing, I would say that awareness that we're addressing real world opportunity, and then how to navigate the conversation in a collaborative way. We really do not like it when suppliers try to divide and conquer us. So really bringing us all together to the table with opportunities at the same time is a great way to approach it. And then having the hands-on ability to tailor and accompany our clinicians through value mapping and redesign is really critical. So thanks for your time and having us.
Thank you so much. Aaron, you want to take us home?
Sure. The last point I would make, just to add on to what was already stated, is I think data is really important to be able to showcase that and highlight all of that. So you can have all of these goals, which are really great, but if you can't sort of show how you're doing and how you're trending towards that and showing impacts, because data is king, that's really where there's going to be, it's going to be a trouble spot. And so that's really what we use is the reporting tools from different solutions and otherwise, and making it easy to be able to access that data is really super important for vendors to be able to tackle and to provide that information so that outcomes can really be reported and showcased well. So data and reporting would be truly key in my view.
Fantastic. Well, I hope everybody's taking notes. Here at Redox, we have these types of conversations because we want to share these insights, share learnings with the industry at large. We want the next round we want digital health products to be better and have a bigger impact for patients and providers. We want health systems to, help us alleviate these very real challenges that they face in day to day. And we do believe in the potential for technology to, help with a lot of these things, but we also realize that we're not quite there yet. So that is the hope and the frustration that is digital health, but we're all in it together. We're all working on it together. So really thank you all for joining. We'll continue to have these types of conversations. We'll follow up with the full report details. Again, utmost appreciation to the panelists for sharing your time and expertise. Really incredible stuff all around. And I hope you all have a great rest of your day.